and we'll chat at the end of your presentation. Thanks so much.
Okay. Okay, can everyone hear me?
Perfectly, yeah.
Okay, you can see my screen. Okay, great. So firstly, thank you to Project ECHO and Gecko for allowing me to do one of these fellow presentations. And my one this afternoon will be looking at esophageal malignancies. Okay. So esophageal cancer is the 8th most common cancer worldwide, with an estimated 456,000 incident cases, representing about 3.2% of all cancer diagnoses annually. It's also the 6th leading cause of cancer mortality worldwide. And in South Africa, esophageal cancer is the 8th most common cancer in men and 11th in women, with the highest incident in the Transkei. As I'm sure most of you know, there are 2 main subtypes. It's squamous cell carcinoma and adenocarcinoma, which I'll be referring to as SCC and the American EAC in the future slides. So both subtypes are associated with distinct geographic distributions and risk factors. And on this map, you can appreciate, this is for squamous cell carcinoma. They talk about the 2 geographic belts. So it's the dark blue, and the first one you can see, it's called the Asian belt, which is across Asia. And then there's the belt, the dark blue belt, also on the eastern coast of Africa, from Ethiopia to South Africa. This figure, as you can see, demonstrates 3 maps. So it's comparing the income status in A and the incidence of squamous cell carcinoma in map B and adenocarcinoma in map C. And you can appreciate the higher risk areas for adeno-CA are your developed countries, so more your UK and North America. So first we'll start with squamous cell carcinoma, which is the most common form of esophageal cancer worldwide, and it continues to be the most prevalent type in the East and Africa. And although it is known to be more common in men than women, the ratio can vary in some regions. So in some low risk areas, for example, the USA, the ratio is 4:1. In high incidence areas like China, the ratio is even lower, approaching or even exceeding a 1:1 ratio of men to women. There's a known high incidence in older people, age over 65 years of age. And then the etiologies and risk factors vary in low and high income areas. So in your more developed or industrialized countries, the 2 most important risk factors are your tobacco smoking and your strong ethanol consumption. In developing countries, it's thought that it's more nutritional deficiencies that have a stronger relation to cancer incidence. And then other risk factors just to be aware of are your low socioeconomic status, your high temperature food, so your hot teas, achalasia, lye ingestion. So lye is quite a toxic caustic liquid, and then your rare syndromes like your Plummer-Vinson and your Fanconi anemia, and then also tylosis. And just for those of you who don't know, tylosis is it's an extremely rare hereditary condition. It's autosomal dominant, and patients have this hyperkeratosis of the palms and soles and thickening and fissures of their skin. And esophageal cancer, there are 2 types. There's type A and B, and type A is the later age onset. It's usually 5 to 15 years. And this one has a strong association with esophageal cancer. Also remember, other risk factors are HPV as well as radiation injury. And then it's also been noted that there are a few factors that are shown to be protective against squamous cell carcinoma. So this includes obesity, the use of NSAIDs, and aspirin. Moving on to your esophageal adenocarcinoma. So it's the 2nd most common form, and it's really the most predominant type in the West. It's 8 times more common in men than in women. And so in the past, it was squamous cell that was the most predominant form in the West and the East. But this geographic incidence has changed, and it's thought to be due to the increase in GORD and obesity in developed countries. As I said, it's 8 times more common in men than women. It's also 5 times more common in Caucasians than African Americans. And similarly to your squamous cell carcinoma, tobacco smoking is also an important risk factor. GERD is probably the most important risk factor for the development of adeno-CA, and Mustafa gave us a really good overview of our Barrett's 2 weeks ago. And just to reiterate that patients with Barrett's esophagus have a 10 to 55-fold higher risk of developing adeno-CA. Also, there have been several protective factors which have been identified, and this includes your H. pylori, your PPIs, statin use, and also high intake of fruit and veg. Again, this is just a nice table that summarizes the relative risk factors for both squamous cell and adenocarcinoma. So squamous cell, the important ones here are your cigarette smoking, alcohol consumption, caustic injury, and also a history of head and neck cancer and radiation. And adenocarcinoma, the main two are your Barrett's and your reflux esophagitis. So with regards to the pathogenesis of esophageal carcinoma, we know that human cancers in general, they occur in this multi-step manner as a result of accumulation of both epigenetic and genetic alterations. It's a combination of environmental factors, hereditary factors, and acquired genetic alterations, which all likely contribute to the development of esophageal cancer. With regards to adenocarcinoma, there's usually a gradual accumulation of somatic cell genetic abnormalities that occur during the known metaplasia, dysplasia, carcinoma sequence. However, in squamous cell carcinoma, it's thought more to arise from this hyperproliferative epithelium, which progresses to low, intermediate, and high-grade dysplasia, and ultimately leads to your invasive squamous cell cancer. Some genetic mutations have been shown to be related to esophageal cancer. Some examples are your EGF receptor 2, that's your HER2 mutations, as well as your tumor suppressor gene TP53 mutations, and then also some mutations of your apoptosis regulator genes. With regards to the clinical presentation of these patients, so patients, both adeno and squamous cell, they have similar presentations. So in the early stages, the vast majority of patients are asymptomatic until they start to present with progressive dysphagia, which is initially solids but progresses to liquids in the later stages. And the symptom is often delayed because a lot of these patients adjust their dietary intake. And remember that solid food dysphagia usually occurs when the diameter of the esophagus becomes less than 13 millimeters. When patients sort of localize a point of difficulty with swallowing, it's quite a poor predictor of the actual location of the mass. Remember, dinophagia can also be reported. It's less common though. And when this is reported, it usually does, you should consider the presence of an ulcerated lesion. Less common presentations are your iron deficiency anemia, palpable lymphadenopathy, chest pain. And when patients present with chest pain, this could possibly suggest invasion of the periesophageal structures. You can also get an esophago-respiratory fistula due to tumor erosion. And these patients can present with a refractory cough, recurrent pneumonia, pleural effusions. They can also get an esophago-aortic fistula. And these patients can present with massive upper GI hemorrhage. Remember, hoarseness is another rare presentation, and that's due to involvement of the recurrent laryngeal nerve. And then obviously, patients can present later with mets to the lymph nodes, lungs, liver, brain, and bone. Moving on to diagnosis. So lab tests are pretty non-specific. They can reveal an iron deficiency anemia, low albumin, maybe hypercalcemia as part of a paraneoplastic syndrome. But the diagnosis is primarily made by endoscopy with biopsies. And the endoscopic appearance of adeno and squamous cell can have a very similar appearance, but the majority of your adenocarcinomas, about 3/4, are usually found in the distal esophagus, and the majority of your squamous cell carcinomas are in your proximal to middle esophagus. And remember, they've got a wide variety of presentations. So it can be a mass, a raised nodule, ulceration, depression, a stricture, or even a subtle mucosal irregularity. And then with regards to other modalities that may aid in your diagnosis or confirm your diagnosis, your simple chest x-ray, a barium esophagogram, a CT scan. So on these investigations, you may find features of aspiration pneumonia, possibly air fluid levels in patients with pseudoachalasia. METs may be seen, effusions, and then, as I mentioned, your fistulae. And then also remember your additional endoscopic modalities, which can help you identify areas of dysplasia and malignancy. So this includes your high resolution endoscopy, your NBI, your autofluorescence imaging, and your confocal laser endomicroscopy. So with regards to screening and surveillance, so Mustafa gave us a nice overview of the screening for your Barrett's. When we look at squamous cell carcinoma, so as you know, for any other cancer, the rationale for screening is to detect your asymptomatic early squamous dysplasias and your early cancers with the intent of curative treatment. And the primary screening strategy for squamous cell carcinoma in areas of high incidence involves this Lugel's chroma endoscopy with biopsies. And it's been shown to have a specificity and sensitivity of over 90%. NBI is another modality which can be used, and it has been validated. The other high-risk groups, as you can see from the table, where screening is recommended are your patients with head and neck cancers, your tylosis, your achalasia, Asian or African high-risk populations, and those with a history of caustic esophageal injury. But if you note the outcomes, the only patients that really, where it has been shown that screening shows improved survival or is effective for early diagnosis are your head and neck cancers, your tylosis, and your high-risk populations. So this is just quite a nice image. It's your high resolution microendoscopy. So basically it uses a contact probe onto the mucosa, and it can visualize the epithelium, which is sprayed with a specific dye. And then you use this image analysis software, which interprets the images and identifies dysplastic features. I'm not sure if any centers in South Africa have access to this or use this. Moving on to staging. So the staging of esophageal cancer is carried out using the AJCC staging system. This is the American Joint Committee on Cancer. And it separates the adenocarcinoma and squamous cell carcinoma and uses different staging systems for each. Staging is generally performed using several methods, which include endoscopy and biopsies, your endoscopic resection techniques, your multi-detector CT scan, PET scans, as well as EUS with FNA cytology. And you can just see, that's just quite a nice diagram showing you the TNM factors which are considered. As you know, your T is your depth of invasion, your N is whether there are lymph nodes involved or not, and the number, and then M finally is the presence or absence of metastatic disease. So this just shows you the pathologic stage groups for both esophageal adenocarcinoma and squamous cell carcinoma. And remember, the importance of staging patients is that it affects your management decisions further on. So this figure basically shows correlation of survival and the T, N, and M stage respectively. In the top three bars are your squamous cell carcinoma, and then the bottom three are your adenocarcinoma. And basically, in summary, you should be able to appreciate that the deeper the invasion, the more lymph nodes involved, and the presence of METs predicts a much lower survival time for these patients. Moving on to treatment. So with regards to the treatment or the management of esophageal cancer, really a multidisciplinary team approach is essential. And it requires input from surgeons, from medical and radiation oncologists, from gastroenterologists, radiology, pathology. And remember, palliative care is a very important aspect to the management of these patients. So in order to select proper treatment, factors to be located are your tumor location, the staging, the histologic type, medical comorbidities, and also very importantly, your patient preference and decision. And then just some general principles. So surgery is a standard care for medically optimized surgical candidates with a localized non-superficial tumor. For patients with a localized tumor who are not surgical candidates, definitive chemoradiation with curative intent may be considered. And for all others, basically those with metastatic disease, palliation is recommended. So as I mentioned before, the importance of staging your patients is that the management is tailored according to the tumor stage. So this is quite a nice basic summary of the treatment of cancer at different stages. So for your stage 0, which are your very superficial early lesions, endoscopic and or surgical treatment is used. For your stage 1, you look at a combination also of your surgical treatment and chemoradiotherapy. The same for stage 2. And then as you progress to your stage 3, it's your adjuvant and neoadjuvant treatment around your surgical therapy. And then finally, stage 4, which is your metastatic, it's really palliative care strategies that are used in these patients. So just looking at specific treatments, so resection of the esophagus with an en-bloc lymphadenectomy is the cornerstone of curative therapy for patients with locally advanced cancer. Surgery alone can also be considered for patients with T1B and T2 cancers without nodal involvement or without METs. In your patients with T1 to T4A tumors with lymph node METs, surgery in conjunction with a multimodal approach. So that's your adjuvant and neoadjuvant therapies. And the final outcomes of patients undergoing esophagectomy are dependent on stage, comorbidities, the patient's performer status, and very importantly is the surgical expertise and the center volume. Because remember, esophagectomy in itself has a potential for very high perioperative morbidity and mortality. And then several surgical techniques have also been described, and they're influenced by the surgical access site, the extent of lymphadenopathy that needs to be removed, the type of anastomosis, the type and preparation of the esophageal conduit, the pyloric drainage procedure, and the route of reconstruction. And recently, minimally invasive techniques such as your MIA, which is your minimally invasive esophagectomy, has really gained popularity. However, it requires specialized training and expertise. The most common complications of your surgical procedure are anastomotic leaks and pneumonia. And there was a recent study on esophageal cancer survival after surgery without any neoadjuvant therapy, and it showed a long-term survival of 30% at 5 years. With regards to your endoscopic treatments, which can be used for your early stage cancer, so that's your early stage T1A and B, you can use your EMR and ESD endoscopic techniques. You can add a cap-assisted device or multi-band mastectomy, and then ablation can also be applied post EMR and ESD. But remember, as I mentioned before, what's really important is that doctors need to be trained and experienced in doing these procedures. The most common complications are really your perforation, your bleeding, and then remember, long-term complications are your strictures, which you have to advise your patients about. Then as you get to your more advanced cancers, so locally advanced, that's your T2 or with nodal involvement, you will use a combination of neoadjuvant chemoradiation therapy with surgical therapy. For your metastatic disease, you can use systemic chemotherapy, that's an option, and then also consolidation chemoradiation to the actual sites of disease if the patient responds well. For more advanced disease, it's your trimodality therapies with your neoadjuvant chemotherapy followed by surgery. And all of these situations, MDT is essential to plan the best management for the patient. Other sort of mechanisms or that can be used as your radiation therapy alone, plus minus your adjuvant therapy and surgery. And then in patients who are not fit for surgery or choose not to have surgery, you can use your definitive radiation and chemoradiation. And you can see just how important your medical and radiation oncologies are in assisting with these decisions. In patients who have significant bleeding or dysphagia, palliative radiotherapy techniques can be quite useful for these patients. And then with regards to metastatic disease, and remember, most of these patients present late with advanced disease and or METs. So radiotherapy is very effective in dealing with patients who present with obstruction, dysphagia, severe pain, chronic blood loss or nausea. Also external beam or intraluminal brachytherapy, which is more directed. And then remember stenting in your patients with dysphagia, helping them just to tolerate feeds is very important. And it's for fully or your partial or fully covered self-expandable metal stents that are preferred, because they have been shown to, your plastic stents and your non-covered stents are more prone to sort of tumor overgrowth and stent migration. And then remember, chemotherapy in itself has been shown to improve the quality of life and survival of these patients with advanced disease. And the most commonly used agents are your 5-FU, your cisplatin, your platinum agents, and your docetaxel. And then more and more research is going into your targeted therapies and your immunotherapies, such as your HER2 expressing tumors, and trastuzumab is quite a recently used drug, and all of these drugs are showing promising results. Obviously, you know, the main problem is the expense with them. With regards to prognosis, so the best predictors of survival are the depth of invasion and lymph node involvement in these patients. A recent study on esophageal cancer survival showed that the 5-year survival for local, regional, and distant disease is 41%, 23%, and 5% respectively. And this improves to 90% if it's a cancer in situ or T1A. And remember also, prognosis is affected by the histologic type, your grade, the degree of differentiation, and the location and other patient factors. And then I thought I'd end by just remembering, I mean, we all know squamous cell and we know adeno-CA, but just always bear in mind your other esophageal tumors, which I've just divided up there, just a bit easier to remember. So your malignant epithelial tumors, this is your small cell carcinoma, your malignant melanoma, that's picture B, you can see. You can get your benign epithelial tumors as well, that's your squamous papilloma, a simple adenoma, or an inflammatory fibroid polyp. Then remember your malignant non-epithelial lesions, so your lymphomas, your sarcomas, GISTs, and METs, and your benign non-epithelial lesions, which are your lymomas, granular cell tumors, fibrovascular polyps, hamartomas, hemangiomas, and lipomas. Just always bear those in mind as well. Thank you.
So are we done, Thania?
Yes, yes, Prof. Homo.
Sorry, I came late, eh?
No worries.
Okay, but if there are any questions, can somebody indicate by raising their hands so Thania can answer them? There are no hands that I can see. Do you have any reversible risk factors that we looked at, Thania? I missed most of your presentation.
So, I mean, just stopping smoking is quite important, and your ethanol, your alcohol, excess alcohol, just, I mean, stopping it early.
I think you must, on your slide, you had HPV.
Oh, yes, yes, yes.
Yeah, because that's another one that we're looking at. And we're looking at recommending to the national government to vaccinate boys, as this tumor is higher in boys. Okay. And with us, we got all the high risk HPVs except the genotype 18, which most people are not getting, but that is the one that is also covered by the vaccine. So it's one of the things that is preventable. Of course, the smoking and the behaviors that we're speaking about are very important. Mm-hmm. Any more questions from anybody?
I hope that's a good sign.
It's a very good sign.
Thania, are you aware of any drugs that could be a risk factor for cancer?
For esophageal cancer? No.
So think of a drug that can cause esophagitis.
Oh, so your bisphosphonates? Possibly?
Yeah, so bisphosphonates have been shown in post-marketing surveillance to be associated with esophageal cancer. Okay. I mean, obviously, this is not a randomized control sort of study, so we really don't know the size effect. But okay, that's something to think about, especially patients who've got osteoporosis who are taking them on an ongoing sort of chronic level.
Okay, all right.
Yeah. The other risk factor that I'm not sure if you mentioned is extensive gastric atrophy. Did you come across any information on that? Extensive gastric atrophy
Yeah.
for squamous cell carcinoma.
Oh, okay. I don't think I did. Okay.
Yeah. Because what that led to was the non-acid reflux, which we found to be higher in patients with squamous cell carcinoma and extensive gastric atrophy. And the Australians also did the same. And the problem is that it's not associated with H. pylori. So eradication of H. pylori is not one of those. But I guess that explains squamous cell carcinomas in all those conditions that causes extensive gastric atrophy, which I remember on one of your slides, you had that. And that's how you get malignancy from there.
Okay.
If there are not any questions, then...
there, I think Zama is said something.
Hi, thanks. Sorry, I'm also struggling with the connectivity issues this evening. Thank you, Thania. Thank you, Prof. Kom. I just wanted to ask from the risk factors point of view, the one that I read about is weight, and extensive weight, particularly for adenocarcinoma. Is weight loss potentially, or is the reduction in weight, does that confer improved or decreased risk? And then the second thing I wanted to ask was, is there a role for chemoprevention for adenocarcinoma, NSAIDs, statins,
and aspirin? Yeah. So I haven't, I'm not quite sure actually about that weight loss showing a decreased risk. I'll look into that. And then I also didn't read anything about actually using aspirin and NSAIDs as chemoprevention.
Yeah, the problem with weight loss is that obesity is associated with gastroesophageal reflux, which is in itself a risk factor for Barrett's and adeno. Now, it's difficult to jump from obesity to cancer. So the risk factor may be based on the fact that you are, the more obese you are, the more you are at risk of gastroesophageal reflux disease. Chemoprophylaxis at the moment, there isn't anything available for that. And there is not even a single study that's looking into that for either be squamous or adenocarcinoma that one came across. I saw another question, I think.
Cecilia.
Cecilia, can you tell us what you wanted to find out? Cecilia, can you hear us?
Oh, she's saying the mic doesn't work. But I can see her question. She's basically asking, does stenting affect resectability in a patient that may benefit from neoadjuvant? So, I mean, as far as I know, and I read that, stenting is used for your it's a palliative treatment or your advanced stages. And as far as I know, they can still be offered neoadjuvant therapy. Prof. Korma, I don't know if I'm correct there.
Yeah, the stenting, it depends on which stent you're going to use, because if you're going to use the non-removable one, which is the one that's not covered, then it would affect it. But if you use the removable one, that has a problem of migration up and down, but we use that mainly to get the patient nutritionally suitable for the therapy. So it doesn't if you use the correct stent, but if you use the incorrect one, which is the permanent one, then there's a problem there. Okay. Now, Francis has his hand up. Francis?
Yeah, Thania, thanks so much for that. And Prof, thank you so much. I was just looking at one of your slides, the one that talked about the risk factors and the protective factors. And you did mention about PPI, but at the same time, you also mentioned H. pylori. And I'm just thinking how H. pylori has some protective mechanism for esophageal cancer. I've been trying to think, and I don't seem to get that very clear within my brain. Maybe you will throw more light if that is what it means.
Wait, so you're talking about this slide here, the H. pylori and PPI being protected?
Yes. So PPI, yes, it's understandable, but I don't seem to get very well how H. pylori, the exact protective mechanism.
Well, so remember, H. pylori in itself is a risk factor for gastric cancer.
Yes.
So I don't know, I sort of just inferred it from there. That was my understanding.
So I thought it is there as one that protects or has some protective mechanism for esophageal cancer, because it is PPI is there which will have protective mechanism, but then you also put H. pylori the same column with the PPI. So is it that it exerts some protective mechanism or is a predisposing factor?
Innocent, I think it depends on which cancer you're talking about. For the adeno, H. pylori is protective in that the reflux of the acid goes down. But however, the extensive gastric atrophy I was talking about results from both PPI and H. pylori, therefore likely to get squamous cell carcinoma. So you can see the dilemma that we have. But the studies are still not yet, they still not have yet confirmed as far as the squamous cell carcinoma is concerned. But H. pylori is protective against gastroesophageal reflux disease and therefore adeno, but not squamous.
Okay, all right. Thanks, Prof.
Remember, H. pylori actually was shown to have the inverse relationship to GERD.
Yes. Okay, any more questions?
Mustafa has a question.
Okay, Mustafa.
Thanks, Thania. Thanks, Prof. I just want to clarify, like in American College of Gastroenterology guideline, they talk about antineoplasm, aspirin and NSAID. It's a controversy, but it might help to, as an antineoplasm to treat, to relieve or to decrease the risk of paroesophagus, then from there to adenocarcinoma. Is that part of treatment for adenocarcinoma, oesophageal adenocarcinoma or not?
Okay, Thania, you want to say something or should I?
You can go for it, Prof.
Yeah. Remember, aspirin has been thought of to prevent a lot of malignancies. If you think about it, initially, before even this came through, we were looking at polyps of the colon. It was meant to prevent adeno type of malignancies in the colon. So the American Association is using the same this thing to the esophagus, but they're not talking about squamous. They're talking about adeno. And even then, there is not proof yet, because you need a long-term study to show that it is protective. And what limits the situation is that the adenocarcinoma in Western countries in itself has gone down, and squamous globally is increasing, because squamous cell carcinoma occurs in those countries where the resources are low, and then adeno in those places where the resources are high. And therefore, the studies are going to be difficult to prove that aspirin will prevent that, based on the effects that they won't have enough samples, you won't have enough time to prove that. But it is mainly postulated. And usually Americans, when they come with something, there's a disclaimer at the bottom to say that based on whatever they have, so that they don't really are held responsible for whatever they say. But we don't have anything that says really that it prevents that at the moment. And you're talking about adeno, not squamous. It wouldn't do that.
Yeah, adenocarcinoma. Yeah, thanks.
Okay, any more questions?
So, Prof, I think there's one there from VG. Just Thania, what are your thoughts on screening for SCC in South Africa? I mean, I think, you know, if we had the resources for it, I think it would be great. You know, we are on the belt, but like Prof also mentioned, it's just our lack of, you know, we don't have the resources, I think. But if we could, you know, sort of try and focus on those high-risk groups, as that slide that I showed, your head and neck cancers, your high-risk older African populations. You know, if we had the resources, I think it would be great.
Hi, Thania, if I can interrupt you there. So say if we asked you this in the exam and you say, okay, your resources are limited. Can you just expand on which, resources?
So I would just, I mean, you know, so firstly, you know, patients' access to a basic upper endoscopy, number one. Number two, also to centers where they have the expertise in sort of screening in squamous cell carcinoma surveillance. And then those special.
Have you actually heard of any other screening methods for squamous cell cancer of the esophagus that will not require a scope?
A scope, yeah. So I know there are some non-endoscopic. So they do these. It's sort of like, I think, a balloon that a patient swallows, and you can do some cytology scrapings from there.
Like a sponge.
A sponge, yeah. And then they also, I think they're breath markers and DNA markers as well.
Okay, that's fine. That's fine.
I think we have time, so I'm going to put you on the spot, Thania. If it's okay, Professor Khomo, just to follow up on Viji's question, if you were asked a question about screening and what criteria should be filled in order to roll out a screening test. So this is more of a stats question. There are generic screening criteria that should be met in order to roll out a screening test. One, I think you said, is resources cost. What are the other 3 or 4 or more, if you can, factors?
Oh, my.
This is just for fun, for my fun.
Do you, I don't know if you look at numbers needed to treat? Or to
I guess you're trying to say that it should be common and it should be cost effective to treat it, right? Yeah, that's a criterion. Other criteria? So you want the disease to ideally be detectable in its preclinical stages, so early.
Yeah. Because
if you're going to institute a screening test, there's no point if the disease tends to present a bit later. And, you know, adenocarcinoma or squamous cell carcinoma tends to present late, unfortunately. And then that kind of test that you want to administer must be acceptable to the population that you want to administer to. It must be cost effective. And the screening test has to have a high accuracy against the gold standard. So you'd need sort of some numbers in terms of sensitivity and specificity of the test in order to put it out. Those are just some of the sort of factors that you'd want to consider. There are others, but it's just to put you on the spot, because in the exam you may get thrown a question that's like offhand and you kind of have to come up with sort of a generic answer. So always stick to basic principles, even if you don't know the detail. Just sort of give sort of a general sort of answer.
Okay.
Yeah.
Thanks. Thank you.
Yeah, the screening of squamous cell carcinoma, what makes it difficult is the way it spreads. It's not necessarily only the fact that it presents late, isn't it? Thania, how does it spread then? So you can take the fun out of Mashigo.
I'm not to understand the question. How's it spread?
In other words, why does it present late? Let's put it that way. It's not like the patient.
I think a lot of it is because the patients, you know, eventually become symptomatic with dysphagia, but they then tailor their diet.
No, it's the rich lymphatic system of the esophagus. So it goes down the tube rather than out. You understand that? So the dysphagia will present late because by that time, the lymphatic system is kind of already exhausted, then it goes inside. But squamous cell carcinoma is at an area where the lumen is already small. So that's why, I mean the adeno, sorry, that's why it will present early. Mustafa had a question, I think I saw his name somewhere.
There's one here that's just asking, how does the low social economic status predispose?
I did ask for the aspirin, yeah.
Oh yes, okay, the low social economic, yeah. Tell them, Thania.
So the way I understood it is just in those groups, it's considered to be linked to the nutritional deficiencies.
That's correct.
Yeah.
That's correct. And the behaviors, because the form of entertainment will be alcohol and smoking.
Alcohol, yeah. Okay.
Any other questions?
Bad dentition is considered a possible risk factor.
Yeah, for which cancer? We should be specific. It is, but it's more for squamous, isn't it? Not for adeno, squamous cell carcinoma.
Yeah. Okay. And then what is the role of EUS in staging?
That's a very important.
So I would assume that EUS would be important in looking at your lymphatic involvement.
Exactly. You can pick it up even when it's submucosa.
Yeah.
Here's the story that we had.
Yeah, and if I can expand on that, Thania, so you obviously scope a patient, and then sometimes you may get to refer a patient if you do EUS by the surgeon. And he says, I have a patient, I saw a lesion in the esophagus, I've taken a biopsy of it, it looks like a squamous cell CA. The patient can still swallow, so it's not complete dysphagia, and asks you to do a EUS.
Mhm.
Is there anything specific that you would say to the after performing the EUS, or what specific? Well, I think you will first do after the scope. You would first ensure that which staging, like a test, would you first ask for?
So I mean, this is assuming you've done your biopsy with your endoscopy.
Yeah, it's come back as a squamous carcinoma. Patient may be operable, is in reasonable.
So you'd want to do a CT, a cross-sectional imaging.
Okay. Why?
Well, just looking at lymph nodes, lymphatic spread, and mets to other organs.
It's the M staging, isn't it? Especially, esophageal cancer is fairly local, and yes, you may see some lymph nodes, you may get some idea in the CT, but mainly it's because of the M stage. So if you have the M, if they already have an M stage, then you don't really need to actually do EUS now, isn't it? Because it's already spread beyond the esophagus. So what is your role now of EUS in staging after a CT showing you that there's no no metastases?
It would still be for lymph node involvement, wouldn't it?
But extra than lymph node involvement. Okay, I'll just summarize it. Yes, it is. It does give you fairly accurate end staging, but it's also your
level of invasion,
local regional staging, right? So it's local regional staging. So you want to know if it's a T3, T4A, T4B, whether it's involving the aorta, whether it's already seen in the aorta. And those are the things that EUS can add beyond a CT scan. Well, I have to say, if we get excellent CT scans, they may also be able to inform you as well if you've got high quality CT scans. But roughly speaking, EUS is for local regional spread, especially those T3, T4 and T4A, T4Bs that actually influences the onco-surgical decisions as well. Okay.
Okay, thanks. Thank you.
Mustafa, your hand is still up. Is it the same question?
No, other question. I just want to clarify, Thania, is it acoustic injury or acoustic ingestion? It's a risk factor or as a cause of squamous or adenocarcinoma of the esophagus?
Yeah, so it's a risk factor. Yeah, so remember, it's chronic epithelial damage. It's chronic inflammation, fibrosis. So yeah, it is a risk factor for squamous cell carcinoma.
Because I'm not sure, as I know it's a risk factor of squamous esophageal carcinoma, and
so it's a risk factor for both squamous and adeno.
No, I mean, okay, it's a higher risk for squamous and it's increasing the fall. It's 1,000 to 3,000 times. Well, I'm asking this question, okay, because it's written there specifically in patient with acoustic ingestion. So you have to start, screening or surveillance of the patient, after 10 to 15 years from the time of ingestion, then every 3 to 5 years. Is that related to surveillance for those patients, specifically like adenocarcinoma, squamous carcinoma?
Are you referring to that table that I put up?
Well, I mean, as a
squamous cell carcinoma.
For squamous adenocarcinoma, because you mentioned. So can we use that one as every 3 to 5 years as a part of a recommendation of surveillance?
Yes, I mean, they say endoscopy every 2 to 3 years, starting 10 to 20 years following the injury. Does that?
Okay. Are you happy, Mustafa?
Yeah, I'm here. Yeah, it's fine.
I'm saying, are you happy?
I just want to clarify because we did talk about, no, what I said, what we talk about, we said we don't have the resource limited and all those story for the surveillance, but there is already guideline regarding the surveillance, but specific to patient for acoustic injury, a risk for the squamous or adenocarcinoma. Can we use that specifically as a surveillance for every patient? Doesn't make different or doesn't matter the cause or the risk factor of squamous or adenocarcinoma.
The important thing is which acoustic injury, ingestion did the patient take? Is it acid? Is it alkaline? Because alkaline is more squamous, isn't it? Whereas the acid is lower down. And the alkaline ones, apart from screening, they themselves, they have problems, long-term problems.
Yes.
So without screening, you're likely to pick it up anyway. But the adenos are the ones that may follow what Thania is suggesting. I don't know if you've seen anyone who's taken the one where there's esophageal damage, gone and coming back in 3 or 4 years. They're always in your department and they almost become psychotic. And I think most of us have come across those, but the adenos may need to follow the program that she's suggesting. So it's important to just not say cancer of the esophagus, but to say which one you're talking about. Yeah. You want to follow up or you're okay with that? Because I see time is going on. Okay, so I think it's 3 minutes to 7 now. If there are any more questions, I'll close the meeting. I'll thank Thania for excellent presentation.
I am Paul. I think I just added one small one there for the end of the evening for you, Thania.
Thank you.
What are the pros and cons of SEM versus brachytherapy for palliation? Which one will you recommend and why?
I'm not too sure. I guess with just from what I know, if I think of the stent placement, there are risks with that. Your perforation, there's risk of tumor overgrowth, there's risk of dislodgement. Brachytherapy, and sometimes for the SEMS, you'll have to go back and put a second stent in. Brachytherapy, probably not. I'm going to have to read up some more on that. I'm not so sure how many sessions.
I ain't going to expand on it. All I'm saying is it is worthwhile just to go and compare the two. And there have been studies. I haven't seen anything like sort of recently, but trying to compare SEM versus brachytherapy, which will be a more suitable, which will be more suitable, and obviously looking at expense, cost, long term as well, how suitable. So it may be something you might want to just sort of go over at some stage.
Oh well, yeah.
Okay, thanks.
Thank you.
You done, Vijay?
Yes, Professor Como.
You're not coming back. Okay, now I can start again. Thanks, Thania, for an excellent presentation. I missed half of it, but I've seen it because you sent it to me before, and I think it covers everything very well. We'd also like to thank ECHO, UNM, and the ECHO India team for their support. The feedback is available on the chat, and recordings will be available from Gastro Foundation website. And again, we'd like to thank Gastro Foundation. The next meeting will be on the 28th of March. And I think you guys have the topic. It says approach to nausea, vomiting. And Zamo, Mbele, and Vijay Naidu will be presenting.
Great.
All right. Thanks.
Prof, thank you.
Thanks.